Yeah.
Thank you, sir. I really appreciate. Yes, so because it's going to be a period of learning, we're not going to waste time. We're going to start the program straight away. We will be taking comments at the end of the presentation. So please, if you have anything to say, kindly hold on to them and keep them until it is time for contribution from the participants and whoever is present at this meeting. I'm going to leave the floor to the speakers on to use any method that they have agreed on that will be used in this presentation. But before we start, let me read the very short profile of our speakers. I'm sure from our adverts, many will have seen about
Good
them,
evening.
but it's still important that we read them out. Good evening, ma'am. Okay. Can I go ahead? I thought somebody was asking a question.
Yeah, no, go ahead, sir. Go ahead, sir.
Okay, thank you very much. So let me read the profile as it was sent to me. And I'll start with the first person whose picture you saw in the flyer. She is our Oga at home. Her name is Professor Adebola Olanyika. He's a clinical microbiologist who is an expert with years of experience in infectious hazard management. She's a professor at the Ahmadu Bello University Zaria and has been involved in supporting national and multinational programs. She supported NCDC during the COVID era, where she worked directly in the IPC working group in the coalition, COVID coalition. Sorry, can you hear me?
Yes.
We can hear you, but you're faint.
Okay, somebody say you could not hear me, sorry.
We hear you faintly.
Go on, sir.
Maybe you move
sorry,
close.
I'll continue. She has also been a principal investigator for a CDC Foundation project over the years, and currently she's serving in different capacities with the World Health Organization, where she has experience of supporting them as a consultant to Sierra Leone during the Ebola crisis, and also in Gambia during the COVID crisis. It is my pleasure to inform you that she has been appointed as an international ambassador of the Society for Healthcare Epidemiology of America since 2015. Ladies and gentlemen, it's my great pleasure to present to you a physician of note, an expert, a teacher, Professor Adebola Olanyika. Good evening, ma. Thank you for joining us tonight.
Yeah, thank you, everyone. Good evening. I can just put on my video for a few minutes and then I'll turn it off. Okay, thank you.
Okay, thank you very much, ma. All right. And okay, before I go ahead, you recall that on the flyer, we had the name of Professor Suleiman Ismail as the moderator. He's currently held up in the Lagos traffic, but will join us very soon and will take over from here. So I'm just standing in because I cannot be a moderator and be talking when two professors are talking. Let them do their professor thing at their level. So the second speaker is my teacher, and the person that first introduced me to the call conference, right when I was in fourth year, brought me up to come and be part of NAPA conference then when we were students. He was the NAPA chairman national then, and all of us knew what it was to come for programs and attend this. If his teaching tells you 3-star, 2-star, just note it. So he is a pharmaceutical microbiologist, a professor of notes that has graduated many from the prestigious Ahmadu Bello University School of Pharmacy. He has graduated people at both graduate and undergraduate level, masters and PhD, many of whom he has groomed up also to become professors today. So he's a professor in his own right. I'm sure before the end of this meeting today, we see some of his students who are professors also in this meeting. So it is my pleasure not to read a very long, because I also saw a very long profile, but Prof will not want me to read all those things. So let me just stop here and tell you that it is my great pleasure to present to us Professor Busayo Olayinka, a professor of molecular microbiology. Good evening, Prof.
Good evening, ladies and gentlemen. I'll put on the video briefly. Well, it seems not to be responding. Okay, it is now. Good evening.
Yes,
thank you.
Thank you very much, sir. So, Prof, like I said earlier, the meeting starts and you have the floor. However you planned it to go, we are your audience. Thank you, sir. And thank you, ma'am.
Okay, so good evening, everyone. I guess I'm going to start. The topic for today talks about who is the gatekeeper. And I think I want to start by saying I liken the concept of antimicrobial resistance to a house with many doors or with many gates. So if you can imagine a house that has many doors and many gates, you'll understand that there is not a single gatekeeper. If you want to protect unwanted access into that house, you will need to have a gatekeeper at each of the doors or at each of the gates. And that's what antimicrobial resistance is about. It's not a place with only one single gatekeeper, but it's got many gatekeepers. And that probably informs why we have the Global Action Plan against antimicrobial resistance, looking at the different gates, so to say, and that will tell us about who the gatekeepers are. I'll just briefly mention the 5 objectives of the Global Action Plan, and then I'll hand over to Professor Busayo, who will maybe give us an idea of the various gatekeepers that we have for antimicrobial resistance. So if we look at the first objective of antimicrobial resistance, it talks about increasing awareness and understanding about AMR. So who helps us to increase awareness? Who helps us in understanding a bit more? That will give you an idea of who those gatekeepers are. The second objective talks about surveillance for antimicrobial resistance. So how do we go about this surveillance? And then that will tell you who the gatekeepers around that are. The third one talks about decreasing infection. Yeah, if there's no infection, you really would not need an antibiotic. So by decreasing infections, we would decrease the need for antibiotic and decrease the pressure on the antibiotics available. So who are those that help us to reduce infection, or what are the modalities by which we reduce infection? So that also gives us an idea that we have gatekeepers in that region. Then the fourth talks about the rational use of antimicrobials. Now everybody talks about antimicrobial stewardship. So who are the people involved in ensuring that we rationally use antimicrobials, so we optimize the use of antimicrobials? So we have gatekeepers around that. And the last talks about developing the economic case so as to have sustainable investment in the development of countermeasures. And by countermeasures, we're looking at diagnostics, we're looking at therapeutics, and we're also looking at vaccines. So around these 5 objectives, we have various categories of gatekeepers. And at this point, I'm going to stop, and Busayo will continue.
Thank you very much, Prof. Bola. Well, we've seen that. I think one thing we have to remember is that antimicrobial resistance is actually a natural phenomenon. Given the chance, it will take a long time for microorganisms to, change their genome in response to changes in the environment. But what has created the problem is the pressure will create through the use, misuse, and overuse of antimicrobial agents. So when an antimicrobial agent is introduced, it exerts a selective pressure, and we progressively have a more resistant population. So what are the different situations in which antibiotics are used? We've looked at, Rabola told us about the gatekeepers, those that control access in that area. Those are the activities and the roles they play in managing and controlling AMR. But what are the various situations or the type of gates that they will have to man? So we look at the anthropogenic activities, that is caused or influenced by people, relating to antimicrobial use. And we will see that apart from the use in humans for treatment, for diagnosis, for various, for prevention of infection, we see that there are other ways that we have created a lot of pressure on the microbial population. One of them is the use in animal husbandry. And we see that eventually we create a problem by ensuring that animals and even plants become the reservoir of resistant organisms, because the organisms in them will be able to amass the resistant determinant genes and create problem when they move to man to cause infection. There are three major areas of use of antibiotics or antimicrobial agents in agriculture. You have the therapeutic use. You are treating specific infection or diseases. You have the metaphylactic, that is, you want to control treatment of a group of animals after diagnosis of disease has been made in part of them. You don't want it to spread, so you say you want to give all of them. In such situation, who are the people that should know the effect of such use and try to keep the gate to ensure that they do not encourage the spread or the development and spread of antimicrobial agents? So we will see those that handle the animals, even the owners. We've seen that antimicrobial agents are used as growth promoters. I talked about two, and prophylactically also, some use it. Even in aquaculture, I'm sure we must have seen a postal of a meeting that will be happening during the World Antimicrobial Awareness Week, where they will be looking at the effect of antimicrobial use in aquaculture. So for such, who are the stakeholders at that point? Who are the people that should be aware of, like the Global Action Plan, the objective says, the first one, that should have improved awareness and understanding of AMR through effective communication, education, and training. Who will be doing the training? Who will be educating them? So we'll see that we have a lot of people, that a lot of stakeholders that we will need to target with adequate information such that they know the role they play where they are, and they play it effectively to ensure that we do not create a progressively antimicrobial resistant population that might create a problem for us. Now, one of the global action plans says to strengthen knowledge and evidence-based through surveillance and research. Who does that? Who would be involved in finding out if there are antimicrobial agents that are circulating, antimicrobial resistant determinants that are circulating in the environment? Are we having new microbes that are becoming resistant? Such surveillance should be able to pick them. And we know that for some of us that are in the research-based, in the pharma industry, research and development for the development of new drugs is really capital intensive. So what will be the role of people in that category? How do we decide the researches we want to do? The surveillance, is it hospital-based? Are we looking at our facilities alone? What happens in the community? You know, we talk about antimicrobial prescription, antibiotic prescription, which is different from antibiotic consumption. Who is measuring what? How are we doing it? And are we getting the appropriate information or data that we need, that policymakers might need to change some things? So these are some of the things we will have to look at as we look at the gatekeepers. So there, like we have had, there's no one gatekeeper because there are so many gates, so many things to man that would ensure that we optimize clinical outcomes if it is treatment. And I know which of them now, Objective 4, that says we optimize the use of antimicrobial medicines in human and animal health. Now, the idea is to have the tricycle surveillance. You're looking at the reservoir, you're looking at man, you are looking at animals, and you're looking at the environment to know what activities has impacted on the susceptibility of this organism to the agents we have. Now, I believe also that when we look at developing new agents, the major problem has been the lack of incentive in R&D for pharma industries. Because when you have a new drug that you have developed, the idea is, let us keep the new drug. Don't let us overuse it. And invariably, that does not translate to profit for those that have put money into developing it. So we see that big pharma industries will rather go into drug lines that would quickly bring returns on their investment. If the drug is to be taken, daily or 3 times daily for life, you see that that's a big market. But you say, oh, let us keep it. So there should actually be a global, and there is a global incentive to encourage pharma industries, to encourage researchers to look for new agents. Now, I believe in the clinical setting, I will yield the floor to Professor Bola to tell us some of the things we can do to ensure that we optimize the use of antimicrobial medicines. The antimicrobial stewardship programs, what exactly do we want to achieve? It's a multi-sectoral, multi-disciplined group. So what do we want to do to ensure that individuals recognize their position and they know that they have a gate to man and they are manning it effectively to ensure that we do not increase resistance in the environment? Over. Prof. Bola.
Clock, can I come in a little before you continue?
Yes. Okay.
Yes, please. In case we have people that want to join, we have reached the maximum carrying capacity, but we have created a Zoom link, which we're a YouTube link, which we're also sharing to everyone that wants to join. I've also dropped it on this message in case somebody is here that wants to give it to somebody that is outside that wants to join. So it means if you are here, protect your network very well, because if you go out, you will not be able to come back in. Thank you, Prof. You can go ahead.
Okay, thank you. So coming back to the issue of gatekeepers and looking at clinical setting or at the hospital setting, you find out that we have everybody from the patient to all healthcare workers being gatekeepers. Now, let me start with the patient. You find out that there are patients who if they go for any consultation and they're not given an antibiotic, they feel they have not been fed properly. Some would even say, until I get an injection, I do not feel okay. I remember in the days of chloroquine, some people will say, the tablet of chloroquine doesn't work for me. It's only the injection. So we actually have the patients also who need to be educated, who need to be aware of what is antimicrobial resistance. And once they are educated and aware, they will not make some of these demands. Many of us know that when you have a simple cold and what we call it, a common cold, majority of it is caused by viruses. And we understand that antiviral agents are different from antibacterial agents. But most times, once the person has sneezed once or twice, the next thing is, oh, take Septrin, take Amoxil, take Amoxiclav. And so those kind of habits actually also support the development of antimicrobial resistance. So patients by themselves are gatekeepers by not demanding for antibiotics when there is no need for the antibiotic, when there are possibly other over-the-counter drugs that can help to relieve the symptoms until the viral infection is gone. Now, in the clinical setting also, we have the doctors who do prescription. Some prescribe antibiotics, maybe from what I'll call a bad habit. Some do it based on the patient's pressure. And then nowadays, we have a lot of people prescribing antibiotics without doing the necessary tests. So that leads also to overuse of antibiotics, putting undue pressure on the antibiotics and increasing the chances of developing resistance. Then let's go to the lab. Now, assuming a patient comes in and the patient needs to have a lab test, you find out that sometimes the antibiotics that are tested, they just go straight to the broad spectrum antibiotics. Sometimes you could use narrow spectrum antibiotics, and it's preferred to use a narrow spectrum antibiotic when the organism is sensitive to it than a broad spectrum antibiotic. And then there are also antibiotics which sometimes you want to reserve. There was a time I was in a particular hospital and I discovered they were just prescribing meropenem. And I'm like, this is one of our last chances. If we begin to abuse meropenem and then the organisms are resistant to meropenem, then what happens? So even from the lab, they are also keepers by looking out to see if there would be sensitivity to narrow spectrum antibiotics rather than going straight for the broad spectrum or for the higher end antibiotics. And of course, now coming to the pharmacists. The pharmacists are gatekeepers, either in the clinical setting or even in the community setting. Understanding how antimicrobial resistance develops, understanding that if people have to take antibiotic, they have to take it through the right route for the optimized length of time and so on, because and taking adequate dosage. So, well, I believe on this place, we don't have people that count antibiotics. You hear when people will say, oh, just take 2 tetracycline, mix it with this, mix it with that. And, you know, a lot of this happens, especially with patent medicine vendors. And so pharmacists have a role in education. They have a role also in ensuring that adequate dosage for the optimal length of time, the right route, and all of that are taken. I have seen somebody who broke genticin and drank it. So these are some of the areas where we have challenges. And of course, the nurses. I'm picking out the different professions within the health facility. It's not exhaustive, but just bringing out these roles, because nurses need to know that if something is supposed to be given 8 hourly, 8 hourly is actually counting the 8 hours. And there are reasons why some drugs are given 8 hourly, why some are given 6 hourly, while some are given 12 hourly, and really trying to maintain the right hours, because not doing these are things that also increase the chances of resistance. Now, apart from the healthcare personnel within the healthcare facility, we also have like the public health organizations. When we're talking about antimicrobial resistance, and I'm talking about the large public health organizations, maybe like the World Health Organization, the FAO, and so on, there is need for advocacy at the high level, advocacy to governments to prioritize antimicrobial resistance. And so in terms of advocacy, in terms of policy development, policy from the global level to the regional level, and then to the national level, and so on and so forth, large public health organizations have a role to play as gatekeepers in this way. And then we have our policymakers, our governments. As much as we talk about awareness and increasing education, our leaders, our policymakers, our decision makers at the national level, at the state level, at the local government level are also people that need to understand how antimicrobial resistance develops. A lot of them have advisors who may not be competent and who may advise wrongly. And so, but for anyone who is like a champion of AMR, then that is someone who is also serving as a gatekeeper to antimicrobial resistance. So I'll stop here and pass the baton back again. Over to you.
Thank you very much. Let me just mention that in the healthcare setting, in our bid to ensure rational use, we set up our antimicrobial stewardship themes, and a gatekeeper, a group of people that are very important. If management does not buy in and are convinced that it is necessary, it might be a problem. I'm sure that some of us are around that are in the in such teams in our institutions, and we know the kind of problem or challenges we have when we have not been able to carry management along to see the need for having maybe an infectious disease pharmacist or a clinical pharmacist or an infectious disease physician on the team having the various groups of professionals that are needed to ensure that the team, the program serves the purpose. So antimicrobial stewardship is not just having that team. What are they doing? What problem areas are we looking at? So we also have gatekeepers in such places. How do we identify what interventions we want to put in place? There are various types. That means the team will need to know. Well, if the institution has like a treatment guideline for specific disease states, they should know that they will need data from the lab, and the lab people should know that what they generate as antibiogram is important in making decisions on whether to retain a drug on the list, the essential drug list of the hospital or not. So each one of us have a role to play. And I liken it to the orchestra, various instruments. The story was told of whether it was Mozart or I don't know which one of them that was conducting the orchestra, and the piccolo, for those of us that have an idea of what those instruments are, is a very small flute, but it plays a specific octave above the normal flute. Then the piccolo player saw that all the other ones have overshadowed him. He just dropped the thing near himself and stopped. What I'm trying to say is each one of those gatekeepers are important in ensuring that that chain, that we have a strong chain that is taking action to reduce antimicrobial resistance, to prevent it, and to control it. The conductor had to stop, and they were wondering why. He said, "Where is the piccolo?" The man thought he was not relevant, but the person with the trained ear was able to detect that he was not in concert. So we need to know that even, well, maybe we talked about preventing infection. So infection prevention, I know that is an area Professor Bola is vast in, but I just want to make this one to ensure that we understand that if the housekeepers, those that deal with the beddings and cleaning, are important, they need to understand the role they play in breaking the chain of infection. How do they disinfect beddings? How do they launder them? And I know that they have specialized ways of doing all those things to ensure that at the end, we are not bringing out our new drugs to always treat infections that we are not actually sure about. And we are using those drugs at the right dose and for the correct length of time. Like I said, there are various antimicrobial stewardship programs in the various facilities. Now, one thing that is important for some of those types of interventions is to know who takes what decision. There is one specific one I want to point to that I saw. I worked briefly at the military hospital, even though it was as a junior pharmacists, so we don't get to take some decisions on that, like the IV oral switch. You should be able to know drugs that are sufficiently bioavailable to be switched from IV to oral. And that means if you do not have the person with the right training on the team, it should be difficult to do that. And invariably, we will create a problem in ensuring that we have a rational use of those agents. So who takes this decision to switch? It should be a written thing that everyone will agree on, that it is to the benefit of the patient, so that there will be no rancor or problems in dealing with such situations. Drugs like fluoroquinolones, macrolides, clindamycin, once the patient is stable enough to take anything power, there's no need to continue with that. So what are the problem areas? What are special situations that we might need to act in ensuring that we protect the jewels of, somebody referred to antibiotics as the jewels of medicine, that meant that the introduction did much more for public health than any other intervention in the last decade. And that is true. But with that success came the problem: overuse, inappropriate use, that has, gradually changed the microbiome, their resistance, and is creating problem for us, because the rate at which resistance develop is not matched by the introduction of new agents. Remember, I mentioned why it would be more profitable for big pharmas to go into drugs that are for lifelong treatment and do not have times of withdrawing them and things like that. So it is important for us, for each one of us, to know that and recognize people that are in special situations that could be gatekeepers, and if they do not realize their role, to educate them so that they will be able to do what they are expected to do, and we will all be better for it. Now, antimicrobial stewardship in the community is what proportion of antimicrobial consumption takes place in the community. It's reported that the global volume of antibiotic use is 5 to 15 times higher outside the hospital. And one will wonder how. It is through the various other anthropogenic activities of man. Even those that are used in treatment also. Do we have data that can be relied on in our environment? Do we know the antimicrobial consumption pattern? Not the prescription now. And I believe pharmacists also, especially in the community, in community practice, you're sitting on a great treasure that could help in changing the landscape of what happens in terms of antibiotic or antimicrobial distribution and use and consumption. If we will just pay close attention to taking those records, and from time to time, let it be known what has been happening in your environment. What is the self-medication profile, antibiotic self-medication profile in your community? What happens during, you remember during the last pandemic, COVID, what happened to antibiotics? In fact, there were papers that were on antibiotic use during pandemic. We saw that initially, because there was not enough understanding of what it takes to manage the situation, various antibiotics were bandied and used and created a lot of problem. So we need to understand that at special circumstances, also special situations, will create new gatekeepers that will need to realize what their role is and play it effectively to ensure that our antimicrobial agents are protected while we are looking for new ones. And the pipeline for that has been running dry in the last few years, even with the push and pull incentives. I will want to yield the floor to Professor Bola and see if we can round up and use the rest of the time to take inputs from people, from respected members that are attending. Over. I hope I've not been speaking to myself. Hello?
No, you haven't. Okay, so thank you. I was actually also just looking at the time, and I was going to say we need to round up at this time. So I think generally what we have tried to say is that there is not a single gatekeeper. There are many gatekeepers. And the gatekeepers range from the different categories of healthcare personnel. It includes the regulatory bodies in terms of regulations about the sale, about the distribution, and also the quality of antibiotics. It includes the agricultural sector. It includes the patients and also the public. Of course, we have the public health organizations, the policymakers, the pharmaceutical industries, and then we have the educators, those that will help to increase awareness, the researchers, the academia. All of these people that eventually are all gatekeepers to antimicrobial resistance. So at this point, thank you, everyone. And over to the moderator. I hope the moderator is here now. Thank you.
Thank you very much, our distinguished power couple, as we've been calling. It's been a very good one. Professor Suleiman, please, are you in now? Even though I doubt that because of the maximum that we reached since. So others have joined through YouTube. So let me just take the board to the end. I know we have a lot of people here that will want to speak, and we have many of our teachers here, professors here, including antimicrobial stewardship champions in their own might. A member of the national team on antimicrobial resistance and antibiotic use is here. I can see Professor Rebecca Somerokun here. I can see Professor Adesina here, and many other professors. Professor Bola, I know, is here, and our distinguished senior pharmacists, doctors of pharmacy and directors of pharmacy in the hospitals. You can see our very elderly people from the community. I remember when I posted this thing, Dr. Cyril and Wike said that he must join to come and see his old time friend from Zaria. So it's a very big hall today, and we are going to make sure that we all finish from here as quick as possible. This is 9:21, so we'll try and make maximum use of the remaining time that we have before call it a day. So please, if you have a comment that you want to make, kindly indicate, and we'll give you the floor for you. And please be snappy and straight to the point, so that people do not start dozing off. We've maintained 100 since we joined, and we want to keep it like that before people can go to bed. So please, if you have any comment to make, please go ahead and indicate. But before we do that, I want to recognize something that our distinguished speakers have said, that we should all put it into consideration as we deal with antimicrobial agents and infectious diseases. Everyone is a gatekeeper. The community, the trader, the patient, the clinicians, no matter where they practice, are all gatekeepers. If we play our role well, then that jewel will really be a jewel. But at the same time, it could become a cause if we don't use it well. We'll be hearing report about the last time that there was the introduction of a viable antibiotic to practice in the community. And for us to have that situation for over a long period, we should know what we're talking about. These days, sometimes you see on social media, even though sometimes some of them are actually true, you see tests where they conduct MCS tests, and you see R to drugs that you otherwise call them to be power and very sensitive drugs that you don't think you should have resistance to them in the community. But these days we have it, and this selection is something that we should be wary of before it gets out of hand. So thank you very much for this very important enlightenment that we've all had tonight. So please, you can raise your hand electronically, and we'll recognize you if you want to speak, please. I think it's good to start with Professor Somereko to give us something as is happening at the national scene, if she's still here. I think she has been
Thank
logged out.
you.
Okay,
Professor Somereko is still here. I had actually raised my hands. My hand. Just as you were calling on me. So you were in the spirit. I first of all want to appreciate the professor couple. I most especially appreciate the way they had broken it down. This idea of gatekeepers. So we all have seen where we can come in. I'm particularly concerned, at the national scene, the action plan has been launched and the objectives have been highlighted for us here again today. But one thing I want to emphasize from what I think it's the Busayo, the pharmacist now mentioned, that we should be concerned about antimicrobial consumption, not prescription. There's a formula for calculation of consumption. We're not doing it. This is something we pharmacists, especially in the hospitals and the community, should begin to do. I know that currently at LUS, I think from 2023, they've started. The formula is on. They are calculating consumption. Before now, we used to focus on just the prescription, but there's so much difference between the prescription and the consumption. So I want also to have it as a takeaway for us, for those of us in the hospitals. At the national level, there's a lot of concern on education, creating awareness. In fact, training infectious disease pharmacists. All those plans are on. So I'm very sure that, yes, we are now on through the NCDC portal and the task force or committees that have been set up. We're on to something major that should help us do a turnaround and retrieve what we can of our antimicrobials through education. Thank you.
Thank you very much, Prof, for that addition. It's very good. And I think it is good that all this, our drug use studies, drug usage studies should go to those levels of talking about those scientific classification and drugs that are used in our hospitals. That's very, very important, and to give us the real idea of how much drugs our people are using that are antibiotics. Thank you very much, ma'am. All right, the floor is still open for more comments, so you can please also indicate if you want to speak. Professor Inka, anything for us from Sokoto?
Yeah, thank you. But there is not much I really want to say more than what Professor Remekon has said. I love the way she differentiates between prescription and consumption. And when you actually break down the consumption, we'll find out that we pharmacists, we have a lot to do. From the industrial pharmacists that have high volume of their antimicrobial that wants to expire and they are looking into the market for consumption without the normal prescription pattern that we should have, to the community pharmacist that is afraid of sales, that is concerned about just sales, and is ready to sell without having in mind the impact of, because in the first place, they will always tell you, if I don't sell, the next available pharmacy will sell. So these are the things that we need to talk to ourselves. We need to be honest to ourselves first before we can launch out at the national level to start preaching the gospel of this antimicrobial resistance. Thank you.
Thank you very much, sir. We really appreciate that.
Thank you very much.
Please, more comments are welcome. We still have about 10 minutes before we close. As we're waiting for more comments, okay, Dr. Aniwike want to speak. Please go ahead, sir.
With myself, and good evening, everybody. Dr. Busayo, I'm going to call you like I used to call you. I won't put Professor. I hope you don't mind. When I saw your name, and then I was looking at another professor, and I seen Olayinka. I said, your wife doesn't go professor too. Glad to have two of you as professors. Wonderful attainments. Congratulations to both of you.
Thank you.
I'm excited. I just dropped a message because of what has happened tonight. I want to be a formal registered member of IDPaN, and then so that I can begin to get all the benefits and not a serial participant. I listened to you. You talked about gatekeepers in antimicrobial therapeutic management. And I'm thinking that there may be a listing of who the gatekeepers really are. Maybe I missed it in the course of either your presentation or Professor Madam's presentation, but I would like to have a listing of those who are gatekeepers. And then I like what Madam said specifically about starting with narrow spectrum. She gave a typical example of seeming abuse of meropenem. I think these are some of the messages that should be passed and driven into the consciousness of, I believe, the gatekeepers, so that we don't start from the top and go down. We start from down and go up. So if the lower ones fail, the narrow ones fail, then we can apply the more broad spectrum antimicrobial agents. That's basically what I feel like contributing. But it's been a fantastic, very impactful, presentation tonight, and kudos to both of you.
Thank you very much, sir, for that wonderful comment. Okay, I was going to say something before. Okay, Dr. Choma, please just give me a few minutes before you speak. At the end, we'll leave the last 3 minutes for our guests to say a word or two to some young people in our midst. We have the pharmacist mentees who IDPaN is training on good pharmacy practice at a very young age. We have some of them, none of them is up to 5 years post-graduation. Some of them are in their final year, and we still have some people that just graduated and did induction a few weeks ago. they're in our midst, and we want them to learn something, one lifelong advice that our presenters will give to them. So I will now take from Mr. Choma Okonkwo. Please go ahead.
Good evening, everybody. I will definitely not waste time. I'm very, very happy about this presentation. I would also suggest or appeal that this message is on the chat. There's this particular one, calculating antimicrobial consumption. I would love to know more about it. And then I want to tell all of us that this seminar, this training, this little training we just had, if we can cascade it down to wherever we are and implement it most times. Today, it took me 10 minutes of my airtime to convince a very good friend on why she should not take antibiotics. I mean, she was like, Choma, but you know now I have headache. I've just finished treating malaria. And I'm like, what test did you do to confirm you have typhoid? And she said, no, it's just headache. I told her, I also have headache when my blood pressure is high. So what makes you think that having headache is synonymous with typhoid? You know? So I just want to say that, first of all, I appreciate this lecture. Second, let us learn to practice it, all of us, not just me, and teach others who are our friends and don't understand that you don't need to take antibiotics without having a test. And then finally, formula for calculating antimicrobial consumption. God bless us all. Thank you.
Thank you very
Thank you
much.
very much. Okay, so thank you for that comment. Our PSN chairman from Ebonyi State. We have one of our elders in the house also, and who luckily said that one of the presenters was his classmate at University of Ife. Please go ahead and give us your contribution.
Good
evening, sir.
Good evening, everyone. Let me congratulate you for this brilliant presentation. So, yes, thank you. Farmer Kinde on the line, please.
Hey,
so,
Farmer.
my own contribution is, yes, thank you very much. Well done. So, we've talked so much about various gatekeepers, but I want us as a professional body to take cognizance of this. Nowadays, most med reps, they are non-pharmacists. Even some are not science graduates. And all these ones channel the distribution of antibiotics and antimicrobial agents to wrong places. Probably they don't know the importance or the adverse effect of their actions. So we want the manufacturers, the pharmaceutical companies to ensure that they get the right personnel as med reps, so that the channel of distribution of antibiotics will not go to the wrong areas, like patent medicine dealers who are not even supposed to handle all these antimicrobial agents. Because this is one of the areas where they have large occurrence of resistance. So that is what I just want to say. Thank you very much.
Okay, thank you very much, sir, for that snappy one. We'll take the last one now, and so that we can allow everyone to go to bed. And I can see the hand of Professor Ifeyinwa Chijokenwuchi from University of Port Harcourt also raised. But please, can we take your own as the last one before the guests give us their closing words?
Okay, thank you very much. Good evening, everyone.
Thank
you so much, our lecturers. We learned quite a lot. I just want to say something about this issue of over prescription or over, I don't know, laboratory result of typhoid. And from our knowledge of typhoid infection, the clinical manifestation is not really the way we are seeing it, but you see that people just go to the labs and they say S typhi, S paratyphi, 1/, this 1/, is positive, then they just prescribe, especially quinolones and all that. I don't know. I'm just thinking and wondering about it. And now I spoke to one of my colleagues who is a pharmaceutical microbiologist. What is the best way or the best channel to let people know that this thing that we are seeing about so-called typhoid positivity is not? I'm just bringing that as a sense of for us to reason about it. Is it a national orientation? Is it this federal government stuff that is this? Is it to begin to check the labs? I don't know. And the issue of the disc they use, you have some, in fact, when you look at some of the disc, I tell you the truth, you will not even know whether it was made at the back of somebody's house. And yet they turned out this thing out as positivity. And the average person believes it's typhoid. I have a friend just 2 days ago, I was talking about how she can't drink water anywhere because she's fearing typhoid. I said, typhoid, is it as common as this? Oh, no, I don't want typhoid. So I'm just bringing that as a food for thought for us. As you know about these gatekeepers, fine. But this particular issue of typhoid fever and all this positivity, this false positivity, and a lot of them as a thing can be arrested because it is the main source of antimicrobial misuse in our environment. Thank you very much, Dr. Musa. Yes, sir. Thank you.
Thank you very much, everyone. And may I also remind us that the recording of this meeting and all past meetings of CPAN are on our YouTube channel. So if you want to watch this beyond today, please feel free to go to our site and watch this particular one and any other past ones. So I'll now give the floor to our guests to give their last parting words. After that, Dr. Maureen Nwafo, the Vice Chairman of CPAN, who's representing the chairman here, will give us a vote of thanks. And he will also tell, okay, Dr. Sarah and Wiki, you can easily meet Dr. Nwafo if you want to be a member of CPAN, and she'll give you all the details. So please, let's take the last words before we close. Thank you very much.
Okay, so I'll start, and I'm sure Busayo will end, particularly with the word for the younger ones. So from my end, I like the last comment a lot about the issue of typhoid. The unfortunate thing is that the test that is currently being used for typhoid does not detect typhoid. The best way for knowing if someone has typhoid is actually to do a blood culture, but the so-called readout that is being done doesn't have controls, doesn't have anything. So, but I think it's also just playing on the emotions of people. Somebody has a severe malaria, maybe because it's severe, they now try to make it like, oh, you have something very serious. It's typhoid and malaria. And you find out almost everybody that does a lab test has typhoid and malaria. That is something that is important for us to address as a country. And just like you rightly said, it drives a lot of the antimicrobial resistance. But I think generally what I would just like to end with is that to fight antimicrobial resistance, we need all hands on deck. It's a team effort. It's all our collective efforts. In whatever way you can convince one person or educate even just one person about antimicrobial resistance, I think we're contributing to the collective requirement of increasing awareness about this, educating people, and keeping our drugs, the drugs that we have available, to be useful for really serious infection. So I'm going to stop there in view of the time, and I hand over to my husband. So over to you.
Thank you very much, Bola. Wonderful contributions. Professor Shura Mekum, thank you very much, and all the others that have talked. I've also learned a lot of things. For our graduates, colleagues, young colleagues, if it's in the area of antimicrobial resistance, even pharmacy practice, you know that the pharmacist has a great responsibility of educating, re-educating, changing, helping to change behavior. And these are some of the things we need in some of the problems we have, like what has been mentioned on typhoid. So we will need to reinforce whatever information we are passing across. So as pharmacists, let us know that you cannot, there is no practice when you have not been able to conveniently talk to people, interact with them to ensure that they know what they ought to do and they are doing it. So as young colleagues, don't limit yourself. What you've been given much more than you need to practice, but keep improving yourself. A lot of the things you learned, you might think you don't know, you don't need. But as you go and interact with people, be open for opportunities. He says, Churchill, a pessimist sees difficulty in every opportunity. An opportunist sees opportunity in every difficulty. So in every difficulty, what is the opportunity there? Even biblically says it. Whatever it is, be sure to show up. Keep showing up, and you will see that you will move ahead. Thank you very much. It's been a great opportunity for myself and my wife to talk. Initially, they said it was going to be a debate, and I told Professor Joda that we don't debate. That I will end up supporting all that she will say. And we've seen that we have gatekeepers everywhere, and they need to be aware of their responsibilities. That is what is important. You might be a gatekeeper, you might be somebody that could take action to stop the development or the spread of antimicrobial resistance, but you don't know what you ought to do. Those of us that know, let us not keep quiet. The World Antimicrobial Awareness Week would be from 18th of November. Antimicrobial Awareness Week should not be the only time we will talk about antimicrobial resistance and things like that. It should be all the time. Let people know what we are doing wrong that is creating problems for us, so that we can all move ahead with the informed decisions. Thank you very much. Over.
Thank you very much, Prof. And we really appreciate this presentation. Before I call on Dr. Maureen Wapo to give us the vote of thanks and acknowledgement, let me also recognize the presence of Brigadier General Stella Ibe, one of our great support system, who is here with us. Thank you for joining us tonight, ma'am. All right. Dr. Wapo,
Thank
please
you
go
so
ahead.
much, sir. Thank you, sir.
Thank you, ma'am.
It's a brigadier's problem now.
Good evening, everyone.
Good evening, ma'am.
I hope I'm audible. Okay.
Yes,
you are.
On behalf of our national chairman, Dr. Joseph Madu, I want to thank everyone here present tonight to listen to this wonderful presentation tonight. Especially, I want to thank the two professors, the couple indeed that made it a wonderful night. Initially, when I saw the flyer earlier, I called Dr. I said, is it a couple affair? He laughed. He said, Maureen, next time it's you and your husband that will be the next people to debate. So, and it's interesting. Thank you so much for making yourself available to train all of us here tonight. Thank you so much. I want to thank the moderator, Professor Ismailai, and also the coordinator of IDPaN, of CPAN. Thank you so much, Dr. Issa, for this wonderful encouragement and for you to organize this wonderful program. I want to thank all CPAN members. Those who still want to join us, like Dr. Aniwike, I'll get you immediately. You'll be our member. Thank you so much. Thank you, everyone. We've listened to tonight's presentation. We all are gatekeepers. And I pray that we'll put this we've heard today into action, that we should not just be the hearers, but the doers. Let us carry this message all around, that we must have to protect our antibiotics so that the one we have will preserve and it will be good for our patients today and tomorrow. Thank you so much, everyone, for joining us tonight. And all of us who are not yet member of CPAN, we welcome you. Feel free to call on us. We will let you into our great association and interest group of PSN. Thank you so much and enjoy your night. God bless you all.
Thank you very much, Dr. Mwariwa, for our National Vice Chairman. And it's a big thanks to all of you. The way we started, we used the formula that Professor Inka James gave us and use the next 30 seconds to say a word of prayer in our Bedos faith before we call it a night. Because Almighty, help us to preserve the use of antimicrobial agents to the glory of God and the betterment of all human beings. Thank you very much, everyone, and do have a wonderful night rest.
Thank you.
Thank you.
Good night, everybody.
Thank you. Thank you. Good night.
Thank you. Bye.
Good night, everybody.
I think Dr. Osa should put together some of the things we have on this on the chart.
Professor, thank you.
Dr. Isa,
yes, ma'am.
please, some of the things that some of the comments on this chart are very important.
Yes, ma'am.
Please,
yes,
can you find a way of putting them together?
Yes, sir. I'll do that.
Thank you very much.
Thank you very much.
Thank you.